Asymmetry is one of the more difficult parts of mammography. First of all, understand asymmetry is unique to mammography. There is no asymmetry in ultrasound or MRI. They have non-mass, but most of the asymmetries we see at mammography will not correlate with non-mass at either MR or ultrasound. So this is sort of a unique thing. And it's also becoming, over time, oh, I should show you this slide. It is becoming over time with screening mammography the way that we are finding more and more early breast cancers. We're finding them before they become masses. And that's why this is so important. It's also important because asymmetry as a whole category, almost all of them are benign. So how do we pick out the small percentage? It's only about 1% that turn out to be breast cancer. That's the challenge. And that's why I think Mike has chosen to have 3 different talks on this subject, because this is really, where the money is becoming as time goes on, as our technology improves. We're going to find a lot more of our early cancers with this than we will with the more traditional mass and calcifications and architectural distortion. Okay, with that introduction, let's understand the basic difference between a mass and an asymmetry. I'm using the current 5th edition rather than what might be the 6th edition because we don't really know exactly how the 6th edition is going to wind up, although it probably will wind up the way Janice showed you. A mass is a space-occupying lesion seen in 2 projections. If you've got tomo, in certain circumstances, you may be able to call a mass just on 1 projection, but it's only in certain circumstances. A mass always will have convex outward contour. A mass, mammography should be, if it's a dense mass, not a fat-containing mass, should be denser in the center at the periphery because it's thicker in the center than the periphery, so it's going to stop more X-rays. It's going to look whiter. And asymmetry is the opposite of that. Asymmetry is seen in only 1 projection at screening often. At diagnostic, you will have done all the pictures that you need to get to see whether it really is seen in only 1 projection and it's just superimposed tissue. So you'll eliminate the 1 view asymmetries. But key to this is that the asymmetries, instead of having convex outward contour, asymmetries have concave outward contour, and they're often interspersed with fat. Basically, asymmetry looks like normal fibroglandular breast tissue. It's just collected in 1 area which is different than the other side. You can't see asymmetries in a woman who's had a mastectomy unless you have her prior exams where she still had the other breast. Obvious difference between a mass and an asymmetry. A mass is convex outward, and asymmetry is concave outward. Mass is denser in the center. Asymmetries often have fat in the middle. Simple. Now it gets complicated. There are 4 different types of asymmetry. This is different than with mass and with calcifications, where you have descriptors. You have descriptors of shape and margins and all that stuff. With asymmetries, you just have different categories. They're not descriptors. They're categories. And the reason for the 4 categories are because the management is different for each of the categories. As you will see at the end, asymmetry is usually a superimposed tissue. It's BI-RADS 1. Global asymmetry is almost always benign unless it's palpable. That's BI-RADS 2. Focal asymmetry, if you don't have priors, is probably benign. It's BI-RADS 3. And developing asymmetry, whether we retain the title or not, is always going to be suspicious. And that's BI-RADS 4. That's why developing asymmetry was created. It wasn't to set it aside from mass and calcifications. It's just because it has an inherently different management recommendation. And even if developing asymmetry is dropped, You still have to know that if it's a subset of focal asymmetry, whenever it's developing, it's an automatic BI-RADS 4. If you forget that and you think developing asymmetry doesn't exist, you will be making a huge mistake for yourself medico-legally and also for your patients. That's the problem with dropping it, that people will start missing cancers. But that's an issue that's being debated. Okay, we're going to look at each type, and we're going to do a deep dive into how this works. Okay, asymmetry alone, that means you see it in only one view. This is with standard mammography. What that means is that you don't know whether the finding is real or it's just superimposed tissue. Superimposed tissue is often called summation artifact. BI-RADS uses this term. I don't know if that one's going to stay or not, but we used to call it summation shadow. It was changed to artifact because there's really nothing there. It's just an area of fibroglandular tissue overlying another area of fibroglandular tissue, depending on how the breast is positioned and compressed. And it looks like something's whiter and that there may be a finding. And then when you take a picture at a different angle, it's gone. Okay, so what are the data on asymmetry? This is the biggest article. It's by far the largest article on asymmetry. Came out of UCSF. We studied over 2,000 cases. I wish there had been a second article, but nobody has written one since way back when. So this is our basic data. All the patients were followed at least 2 years. Most of them are followed much longer. Less than 20% of them turned out to be real, which means that more than 80% of them were summation artifact. Biopsy was done on only 5% of the cases, and there were only a little bit less than 2% breast cancers. That does not mean that asymmetry is a probably benign finding. Just because you see this number below 2% does not mean that that's a probably benign finding. And the reason is that when you're actually doing the workup functionally, you're only considering biopsy for the real findings. So instead of calculating this with a denominator of all the patients, it should be calculated with only the number where the biopsy is done. And then you wind up with a 10% likelihood of malignancy, which is why an asymmetry is never a probably benign finding. It has to be worked up first to see if it's real. If it's real, then it is no longer an asymmetry. It's one of the other three types. So asymmetry exists only at screening. Once you get to diagnostic, you don't let the patient go unless you know whether it's real. Okay. That's sort of the theory on asymmetry. Now, what's global asymmetry? Well, global and focal, which we'll get to next, are real findings. They're seen on 2 different projections, although there's a little bit of a thing about tomo there, which may be okay. But it's a real finding. You know for sure it's there. It's not superimposed tissue. The thing that makes global asymmetry stand apart is that it's large. It occupies at least a quadrant of the breast. What is our experience with global asymmetry? The bottom line is it's very limited. There's really only one article on it, and it was done even before BI-RADS started. This is sort of what it looks like. A big area of the breast is denser. Okay. I'll show you this and then I'll come back to that. This is the article. It's written by Dan Kopans way back before BI-RADS started. But what he described is what we now call global asymmetry. And he studied over 200 cases where there's this big difference in breast density from one side versus the other. Followed the patients for a long period of time. Of these patients, 40 of them, 40 out of the 220 were palpable. Biopsy was done in only 20 of the 40 that were palpable because the others, for whatever reason clinically, they just didn't come to biopsy. but they were followed long enough to know that they weren't breast cancer. Of the palpable lesions, 3 of them had malignancy, only 2 of which were breast cancer. So what does this mean? What it means functionally is that it's a normal variant unless there's a palpable correlate. And if there's a palpable correlate, then you have to decide what to do. At screening, you may see global asymmetry, but those are all women who don't have a palpable correlate. So pretty much at screening, global asymmetry is benign. If you see global asymmetry and you don't trust that the patient is really without a palpable correlate, you can ask the referring clinician, as we do routinely when we see global asymmetry, to do a careful clinical breast examination on the side which has the global asymmetry to make sure there's nothing palpable. If there's something palpable, the woman needs diagnostic mammography of the palpable area, and then you can decide whether there's really a finding. But bottom line is global asymmetry is infrequent. The frequency of global asymmetry in the Copan study was 3%. That is not modern mammography. With modern mammography, global asymmetry is way less than 1%. We see it maybe once, twice a year in 10,000 cases. So it's very unusual. It's still there, and it's still different, which is why it's still in BIRADS. Although maybe one day, because it's infrequent, they'll say, no, we don't have to bother with it. But it is different than focal asymmetry because it's such a large area. Now, focal asymmetry is where it gets complicated. And focal asymmetry is not that uncommon. It's just like global asymmetry, it's a real finding, but focal asymmetry is smaller than a quadrant. Why it was decided to be smaller than a quadrant, I think, is just that it's easier to separate them, and also because the Copan study specifically involved more than a quadrant. I think that's why it's different. But just understand that. You're going to have many, many more focal asymmetries than you will have global. Now, this is a big focal asymmetry, but it's less than a quadrant. Okay? It's a focal asymmetry. Now, you can't ignore a finding like that. If you see that at screening, what are you going to do with this? If you have priors, you're going to look at priors. We'll go through the whole workup. But basically, if you don't have any priors, this is a recall. Because you've got to find out whether there's something underlying it. You've got to do more tests. Okay, that's a big focal asymmetry. I'm trying to get the pointer out of the way. Okay. This is a somewhat smaller focal asymmetry, obviously less than a quadrant. This is an even smaller focal asymmetry. Now, when they start getting small like that, you have to look at them at full pixel resolution in order to make sure that they're really not a mass. But a focal asymmetry has concave outward contour, as this does. And often, although when they're very small, it's sometimes hard to see, they're interspersed with fat. If you have tomo in addition to 2D mammo, then you may be able to see the interspersed with fat better than if you don't have that available to you. But basically, when you see concave outward contour, you're dealing with a focal asymmetry, whereas if you see convex, it's a mass. Masses are more suspicious than focal asymmetry because masses are much more likely to be, quote, tumors, where focal asymmetry is much more likely to be just an island of asymmetric fibroglandular breast tissue. Okay. There are many studies on focal asymmetry. We're not limited to just one. We've got many studies. I've just showed you the ones that were published around the year 2000, but there are other ones that have been published since. They all basically show the same thing. So even the initial ones, which were done with mammography that's now obsolete, that was done with film mammography, it still holds with digital, and it still holds with tomo. Basically, the likelihood of malignancy of focal asymmetry, when you're not comparing with priors, is about 1%. That's why we're talking about it as a probably benign finding, if you don't have anything else to go on. However, in the modern era, as we practice now, 90% of your patients have priors. Only in our practice, only about 10% of the patients have no priors. So this doesn't pertain, because we use the priors to help us decide what to do about focal asymmetry. And that's going to be a bulk of what we're discussing today, is how to use those priors. If you find focal cancer at screening as focal asymmetry, they're pretty much all going to be stage 1 tumors, especially if the woman is screening every year as opposed to every other year or every 3 years. If you look at the European Service screening data, they have many fewer focal asymmetry cancers because they screen later, and their focal asymmetry cancers become mass cancers before they get a chance to screen them, because they're screening less frequently. Okay, now developing asymmetry is a subset of focal asymmetry. In order to be able to characterize the finding as developing asymmetry, you need priors, because you need to see change. And it has to be change for the worse. Obviously, if you saw developing a focal asymmetry and you got another one and it was smaller, you would not worry about it, because breast cancers don't go away with time, unless there's treatment, and there wouldn't be treatment if it's screening. The definition in BI-RADS of a developing asymmetry, and this will hold whether it stays as a category or not as a category, is that it is either new, larger, or more conspicuous. New, larger, more conspicuous. They're all different, they're all worse. They all imply growth. Understand, and this is a common misconception among practicing radiologists, new, which means you didn't see it before, is even worse than larger. Because new means it grew enough so that now you see it, where before you didn't even see it. So new is the worst, larger is the next worst, more conspicuous is the least worst, but they are all indications that the finding may be growing. And I'm going to show you examples of each of the three. All right. This is a sort of typical developing asymmetry. And if you're screening every year, these are going to be small, because they weren't called the last time. So most of these are going to be less than a centimeter. Many of them are even a little bit less than 5 millimeters. They're small. These are the earliest cancers we find. All right, there's one there. You can see it. I'll get rid of the circle so you see it a little better. Okay, that's the previous exam. It wasn't there before. It's there. It wasn't there. You look on the MLO, you see where it is. It wasn't there before. Look on the CC. You see where it is, just over here. Whoops, get rid of that thing. Now you see it. Now you don't. Okay, so it's new. That means it grew. Okay, look at it up close, full pixel resolution. Concave outward contour. It's very hard with these very small ones, these 5 millimeter ones, to see it's interspersed with fat, because it's just not big enough. It's the same thing when you're looking at rim type calcification. The smaller it is, the harder it is to see the rim, because there's no center. Okay, here's another one. But this one is not new. This one's going to be enlarging. It's getting bigger. So there it is. Here it is up close. Again, concave outward contour. And when you compare with priors, it's this size here. and it's smaller a year ago, and it's smaller still, if you can see it at all, over there. Why wasn't it called here? Because the difference between this and this was below the threshold of the interpreting radiologist, and that often happens. Once it gets to here, even though there's not that much difference between this one and this one, when you compare this one with that one, it's big enough to really see the change. So remember that when you're looking at and looking for developing asymmetry, you're not just looking at one prior. You're looking at least two priors, maybe even more priors. If you want to find the early cancers, this is what you have to do. Okay, and here it is on CC. On CC, you can see it a little bit better, so you can see that it's a little bigger than this and even bigger than that. But it's getting bigger slowly. That does not mean there was a mistake made here. If you're just looking at these two, there's not that much change. But if you look at this versus this, then there is a change. Okay, again, looking at it up close, make sure it's not a mass. This one is a developing asymmetry, but this one is the third part, more conspicuous. New, enlarging, more conspicuous. All right, well, we've got the finding, we've got the finding, we've got the finding. It's more conspicuous, more obvious. It looks whiter, it's denser. When we look at it up close, come on, here it has architectural distortion, there it didn't. It's really the same size. It hasn't gotten bigger, but it's more conspicuous. Developing asymmetry, when it's worrisome, is worrisome either because it's new, or because it's bigger, or because it's more conspicuous, and more conspicuous has two components. One component is it might be whiter, and another component might be it has an associated finding, like it looks a little bit more mass-like, or it has calcifications, or especially if it's got distortion or a suggestion of distortion. All right, here are the numbers on developing asymmetry. This is the largest article published, which was published in 2007, which is really the impetus for creating developing asymmetry. It has almost 300 cases. There are no other papers on developing asymmetry. One of the problems with eliminating developing asymmetry is it will discourage future research, because if people don't categorize it as the finding, they can't go back with a structured report and pick out the cases so they can do studies like this. So people who are interested in doing breast cancer research still should use the developing asymmetry category, even if it's not in BIRADS, so that you can flag the cases and do the research. Because we really need more research on this subject. And it's another reason why maybe the BIRADS committee will allow it to stay as an optional category rather than take it out completely and say, you can use it if you want, but you're using it primarily for research purposes. That's an option. Okay. What does it say? Well, these cases were followed, most of these patients were followed much longer than 12 months. The median was 5 years. So these patients are followed long, they're all non-palpable. The malignancy rate is not 2%. This is not a probably benign finding. That's why it's suspicious. It's about 15%. They were all early stage 1 node-negative cancers. Okay, so with that, we're really getting into part 2 now. There's a part 1 and a part 2. This is more the part 2 part, which is not what is asymmetry and what are its subcategories, but what do we do about them? How do we manage them? The first thing you're going to want to do when you see an asymmetry is look at the medical history. The medical history may explain the asymmetry. If the woman has had a surgical biopsy and a substantial amount of fibroglandular tissue is removed on one side, it will create an asymmetry, the opposite non-biopsied side having the asymmetry, because you took out a bunch of tissue that was dense, and now on the other side you have dense tissue, but on the removed side you don't have any. So if you see an asymmetry and there's a previous excisional biopsy and it was substantial, you have to go back and look at the pre-surgical images, then that explains the asymmetry. So it doesn't happen that much because we don't do that many excisional biopsies anymore, but it happens. More important is to review the prior exams. And this is really the most important thing you can do with asymmetries is compare with priors. Not just to pick out the developing asymmetries, but also to identify summation artifacts. And by comparing with priors, even at screening, when you don't have a chance to get any more additional images to work them up, you can identify about half of the summation artifacts, even at screening. Many radiologists don't do it. It takes a little bit longer for a screening exam because you have to go back and look at other priors. But it helps you avert the recall and get your recall rate down without any danger of missing any cancers, simply by looking at more priors, and you will understand why. Okay, here's a one-view only asymmetry. I like to think of it not just as asymmetry, but just one-view only asymmetry. We don't put the one-view only in the report. We just describe it as an asymmetry, and then we say in the report, seen only on MLO view or seen only on CC view. But I think about it as a OVO, one view, only asymmetry. Okay? Now, I'm going to challenge you a little bit. Is this a summation artifact? Can you tell, even without priors, that this is a summation artifact? The answer is yes, but many of you will be uncomfortable in doing that. There's a two-step process, and I'm going to go over it several times in determining whether this is a summation artifact. The first one is, well, you don't want to call something a summation artifact if it's just included on one of the two images and it's cut off on the other one. So it can't be deep. If this finding were way back here, it might not be included on CC view, so you can't use this approach at all. The second thing is the breast has to be mostly fatty. Because what would cause this, if real, to be not seen on the CC view? The answer obviously is dense tissue that's bigger than that might be obscuring it. If you had a patch of dense tissue anywhere on the CC view at that expected depth, which was substantially larger than that, and it happened to overlie that finding, you could have a real finding and you wouldn't see it on the other view. So this approach doesn't work. But the two-step process that does work is if it's not too deep, so that it's definitely included on the view where you don't see it, and also that at that expected depth, there's just nothing that can explain that. Everything else spreads out. You don't need tomo. You can do it with 2D. And for the patients who you're screening, some may have tomo, some may not. For the ones that don't have tomo, you don't need to recall this patient if you are confident of the approach. You're not confident of the approach until you've tried it for a while. So don't just come back from this lecture and go home and try it. That's not the way you do it safely. The way you do it safely is you go back home and say, this is an approach I can use. Every one of these cases that fits, I'm going to recall her, but I'm going to put her name down on a list. And after a year or so, go back and look at your list and see whether all of them were summation artifacts. If they all were, it's working for you. Then you can start using it. You can do your own little research project. You don't have to write it up. It's not part of quality improvement, although you could make it something if you wanted to do that. But this is the way you learn new technology without harming your patients. You do a little bit of recall them all and then see what happens. And if it works for you. It doesn't work for everybody, but it works for many, many people, and it helps them get recall rates down safely. Okay. Tomosynthesis also reduces recall rate. And a good deal of the recall rate reduction comes from identifying summation artifacts, these one-view findings. And you see the one-view finding, you go to the tomo stack, and you look through them frame by frame, slice by slice, whatever you want to call it. And when you get to that area and you go through it, you just see that it's just superimposed tissue and there's really nothing there. If it's a true focal asymmetry, you will see it in sharp focus on several adjacent slices. And it will have concave outward contour. And you'll see it even better. If it's not real, it'll just spread out. And there won't be anything there, and then you just don't call it. Now, for those of you who have read our literature, and you've seen that tomosynthesis reduces the recall rate by as much as 40%, which is true. If you carefully read these articles, you'll see that for some radiologists, it doesn't reduce the recall rate by much at all. Maybe only a few percent. That's a big difference. And the difference is, if you go back and carefully look at the literature, it depends on what your recall rate was before you started using tomo. Because before you started using tomo, if you were using the two-step method that I told you, then a lot of those cases weren't there at all. So you didn't have much to go down in your recall rate. Your recall rate was already about as low as it's going to go. But if you were not using the two-step method and were just recalling everybody, then tomo is going to help you get it down without having to do the two-step method. Okay? Everybody understand that. It's important. Because we're coming up a little bit later in the lecture to what you do in addition to tomo. Okay. Also understand, and this is a misconception by some, that although tomo is very good at identifying some summation artifacts, it does not identify all summation artifacts. There hasn't been a lot published on this, so we don't really know the percent yet, but some patients recalled at tomo for focal asymmetry actually turn out to be summation artifact when you do the diagnostic workup. Tomo has faked you out. It's not perfect. The two-step method is 100% reliable if you use it correctly. Tomo is not quite that accurate. So when you are recalling a patient at tomo, do not completely eliminate from your mind that this can't be a summation artifact. It can be. Okay. Now, that brings us to what happens when you recall a patient for a focal asymmetry. Or any kind of asymmetry, really, but especially for a focal asymmetry. It still could be a summation artifact. It may be a focal asymmetry, or what you think, a one-view asymmetry where you can't use the two-step method. That's most common. Or it could be a case where you think it's a focal asymmetry and you did tomo, but it still could be a summation artifact. So what do you do? Well, here again, there's different ways of doing the approach. One of the approaches is to do super tomo and to do spot compression tomo, because that's better at looking at a specific finding than whole breast tomo. Another would be to do spot compression magnification views. Or if that doesn't work in your practice, just plain spot compression mammography. But I think spot mag would be better. But that's up to you. But you can do one of those things. What you don't want to do is ultrasound. Ultrasound is not part of the workup of a one-view asymmetry because ultrasound cannot answer that question. Ultrasound can answer other questions, but not the question of a summation artifact. And the reasoning is very simple. Let's say you have a one-view finding and you don't see it at ultrasound. Could it still be a cancer? Yes. Our literature is definitive on that. With developing asymmetries, at least a quarter of them, even though you know they're there and you know where to look for them, are not seen at ultrasound at all. They're totally missed. And that's unacceptable. So you can't use ultrasound to say that something isn't important. Well, the other alternative is you do see something at ultrasound. And what you see at ultrasound may well be a cancer. But it also may not be the finding that you saw at mammo. Because the misregistration between mammo and ultrasound is at least 10%. So you still have to work up that one view finding, even if you found something at ultrasound, because it may just be something that's adjacent. And the ultrasound finding may be benign, and the one view asymmetry may be a cancer. So the bottom line is you have to do the mammo workup no matter what the ultrasound shows, which means that you do the mammo workup first. Because if it's a summation artifact, you don't need the ultrasound. When you're doing your workup, you do whichever test is most likely to stop the workup first, because then you don't have to do the next step. It's just like when you're doing tomo, and tomo gives you enough information so you don't need to do diagnostic mammography. You can go straight to ultrasound. It's the same idea, but this is in reverse. With that one, you eliminate the mammo, go straight to ultrasound. With one view findings, you do the mammo first and you eliminate the ultrasound. It just doesn't help. Unless you want to do screening ultrasound for dense-breasted women, that's a different subject. Okay, so here we have a one-view finding. Looking at it up close, concave outward. Now we're going to start to compare with priors. Stay with me. This is a little bit, it can get a little tricky. Do you see it on the prior? No. Okay? So it may be a developing asymmetry. Could it be a summation artifact? Well, could it be that this MLO view was positioned slightly differently than the previous one, or compressed slightly differently than the previous one, so that whatever superimposed here didn't superimpose there? The answer is yes. So looking at that is not enough. If we're recalling a patient and we want to work it up with a mammo rather than with a 2D mammo rather than a tomo, then what we're going to do is we're going to repeat the same view. Do you see it? No. And then we're going to get a spot compression magnification view in exactly the same projection. So if this was a 45-degree MLO, this is a 45-degree spot mag. If this is a 52-degree MLO, this is a 52-degree spot mag. So we're taking two extra pictures. One of them is the whole breast, and one of them is the spot mag. The whole breast makes sure that you know exactly where to look for it. And since it's the same projection, your landmarks are going to be pretty much the same. You know, this stuff here looks like that stuff there. This here looks like this. It's somewhere in the middle, so this is where you're looking for it, and it's either there or it isn't there. And that's pretty straightforward. On the spot mag, you have the advantage of a much finer detail image. So if it's real, sometimes you will see it on this when you don't see it on that, just because spot mag is better. But you have to be careful that you know you're looking in the same location, and your landmarks may be different and may be challenging. If you're not sure you have in the image field, you may have to take more than one spot mag, but almost always a skilled tech will be in the right place, and you will have landmarks. So, for example, this dense tissue here is this, and the dense tissue down here is this. It's going to be somewhere in the middle. The bottom line is, if you do this, if you always repeat the same view and a spot mag in the same projection, and there's nothing there, it is by definition a summation artifact. It works. We've done thousands of cases, and we've never made a mistake. There's never been a breast cancer there. And we follow every single one of them. So this two-step approach works. It's not the only thing that you can do, but it works. And you prove it by calling it negative, and then you see her next year, and the next year there's nothing there. So obviously that's proof it worked. That's how we know it's accurate. Okay. Now, if a one-view finding was done without tomo, then another thing is, instead of doing the two pictures, you can just get a tomo in the same projection because it wasn't done at screening. Many radiologists have practices where some but not all patients have tomo. Actually, the majority of radiologists who have tomo do not use it on all screening patients. We try at UCSF to use it on all screening patients, but still 10 or 15% of our patients don't want tomo. They say, I don't want it, so we don't do it. Now, we still do 2D in addition to the DBT acquisition on all our screens, because we do not believe, and we know we're right, that the 2D mammo is a better mammo than a synthetic mammo. I mean, how many of you, given a choice, would read a synthetic or a 2D mammo? You'd read the 2D mammo, it's just a better picture. The 2D is good, and it shows almost everything, but it doesn't show everything. And where it lacks especially is in focal asymmetries. And those are the earliest cancers. Now, there have been studies, and very well-designed studies, showing that there is equivalence for using synthetic mammo with or without 2D, which has led many practices to drop the 2D because there's less storage and it's lower radiation dose. It makes sense. The problem is that those studies looked at equivalence, non-inferiority studies. Well, we know that tomo shows more than 2D. But if all you have is non-inferiority, it means you're seeing more on the ones with the tomo and the synthetic because it shows architectural distortion better. But it only comes up with the same number of cancers, which means you're missing some of the cancers that you do see at 2D. You're seeing some at 2D and some at tomo. They're different cancers. So if you drop the 2D, you miss some cancers. Understand that. That's the downside of dropping the 2D. Okay. We already talked about that. So what could you do? Well, you could do let's say you already did the tomo and you didn't see it, then do spot compression tomo. That's better than regular whole breast tomo. And that could be done instead of the spot mag. And for those of you who aren't doing any 2D, that's your only option. And that works. And it's probably, it's hard to say whether it's as equivalent as the two-step approach with 2D because there's never been a study comparing the two. I've been after my colleagues at UCSF to do it because we have all the information to do that. We can do it retrospectively because we save the synthetic views even though we don't look at them. We have them. We never look at them. We look at the 2Ds because they're better images. But we have them so we could do the study. It's just that none of my colleagues have wanted to do that study. It would be really important because it would help radiologists decide whether to continue to use the 2D or to drop it. If we ever did the study, my prediction is we would have to keep the 2D. But I don't know. It hasn't been done. And ultrasound. Okay? Okay? Now, we're coming down to real findings. We've eliminated the summation artifacts. Now you're dealing with the real ones. Okay, global asymmetry, focal asymmetry, developing asymmetry. A global asymmetry, as we've discussed, is a benign finding, unless there's a palpable correlate. If you are going to recall this woman, what you're looking for is you're looking for whether there is a mass or masses inside the global asymmetry that is creating the global asymmetry. In other words, you've got an area of dense tissue here on one breast, another smaller area on the other breast. If there's a substantial mass inside the one which is bigger, but it's not forming a border with fat, you're not going to see it. But when you do additional views and you do ultrasound on it, you will see it. And that will account for the global asymmetry. But then you're not dealing with a workup of a global asymmetry, you're dealing with a workup of the underlying mass, and you've got the right answer. You're also looking for architectural distortion, because if there's architectural distortion within the global asymmetry that you didn't appreciate on the screening mammogram, you may well be able to appreciate it either with additional diagnostic mammography or tomo or ultrasound or whatever. You're going to do the workup. And the third one is that if you didn't appreciate calcifications and the global asymmetry with a screening exam, you should do a spot mag view to see whether there are really little calcifications in it, because if there are, then that's an appropriate explanation for your global asymmetry. Because you can have DCIS that doesn't form a border, that doesn't form a mass, but if you see the little calcifications that you didn't see at 2D or at synthetic, you will see them on spot mags. Okay? Now, what about focal asymmetry? Well, focal asymmetry is probably benign finding if you don't have priors. And we're going to get into priors in more detail as we go on, but if you don't have priors, what you're looking for is you're looking for the same three things. If you have any of those things when you work up the focal asymmetry, again, the workup changes from an asymmetry workup to a mass workup or an architectural distortion workup or a calcification workup, because each of these three is much more worrisome than just the focal asymmetry. And remember that a probably benign finding is benign if it's stable for the surveillance period. BI-RADS allows a surveillance period of either 2 to 3 years. Most people are satisfied with 2-year stability to call something benign. Some radiologists prefer to go out to 3 years. BI-RADS gives you the option. Although most people are confident with 2 years. There's no right or wrong answer. Once you've established that kind of long-term stability, your focal asymmetry is read as benign. And you stop the surveillance. Okay, here's a focal asymmetry. You can see it here. We have exams back to 3 years. It hasn't changed in 3 years. If you're seeing this at screening, although it's a focal asymmetry, you don't recall it because it's already 3 years stable. Just make sure there's no difference. But if you look at it, there's no difference. I didn't show you the MLO, but there would be no difference on the MLO as well. Now, what about developing asymmetry? This is the one that's suspicious. Remember, it has a 10 to 15% likelihood of malignancy without doing anything. So you're going to recall all of them. And basically, they're all going to be suspicious unless you can show that it was due to a definitively benign finding. Well, what kind of definitively benign finding can you identify at mammo? Well, fat necrosis, but you wouldn't make that mistake because you wouldn't call fat necrosis a focal asymmetry or developing asymmetry. Intramammary lymph node, you could identify at ultrasound, but it wouldn't look like a developing asymmetry. It looked like a mass. So that wouldn't be it. It could be a cyst that was obscured by dense tissue that was completely surrounded by dense fibroglandular tissue, but there was a cyst inside it, and you didn't see a border, so you didn't see the cyst. And then when you did the workup, you found the cyst at ultrasound, and if the cyst was big enough to explain the change in size, that explains your answer, and it ceases to become a developing asymmetry. You can call it benign. This is the exception rather than the rule. It happens rarely, but it does happen, so understand that. So it's suspicious unless it's a simple cyst, but you still have to do a workup because you're going to be doing a biopsy, and you want to establish extent of lesion size before you do the biopsy. Because if the lesion is more extensive than you thought it was just on the basis of the developing asymmetry, then you want to direct your biopsy to the entire extent of the finding. For example, if you see some calcifications a little bit distant, you want to biopsy those as well. And or if ultrasound shows you more something a little bit further out, you want to biopsy that as well. Okay, so bottom line is asymmetry usually turns out by BIRADS 1, global asymmetry usually turns out by BIRADS 2, focal asymmetry usually turns out by BIRADS 3, unless you have priors, and developing asymmetry turns out to be by BIRADS 4, just about always. And as Janice has explained to you, the 6th edition of BIRADS, the major change relative to all the asymmetries is whether the descriptor remains or not. But remember that if it's not in there, doesn't mean it's not important. You still have to look for the same thing. One of the things I recommended to the BIRADS committee, I don't know if they're going to do it, but they should, is if they drop the term, they have to add text to both the mass and the calcifications part, saying that if these findings are either new or increasing in size or more conspicuous, they are inherently suspicious. That would be not modality neutral, but subcategories of mammo neutral. If they don't say it for the other two categories, dropping it from asymmetry creates big medical legal problems. So if they do, Janice, if you're on that committee, tell them that if they really decide to drop it, rather than to make it optional, that the text that's appropriate for focal asymmetry also needs to be put in the text for masses and calcifications. Because then they'll achieve the neutrality issue that they're looking for, but they have to have it in all three. Okay? All right, let's look at a few cases. All right. Here's a finding. It's enlarged. Looks a little worrisome, doesn't it? I saw that in mammo, I'd be saying, where is it on the other view? Because I want to biopsy that thing. All right, well, here's the other view. It's a problem. Where is it? Well, let's think about our two-step procedure. It's not deep enough to be not included in the field. Is there any dense tissue that might obscure that? Well, this is your candidate. It's certainly not going to be obscured by the fat there or the fat down there. This is it. So let's look at this and this at full pixel resolution. Okay? And you can't really tell when you're looking at it, it's so small. So when you're looking at your screening mammogram and you have the current exam and the prior exam there and all the images are small, you need to look at them at full resolution. So we have this, and we have it here where it's spread out into that. Now, most of you are going to look at this and say, you know, it's probably nothing, but this looks so bad that I'm going to recall it anyway, right? Most people would think that way. I don't think that way. Okay, I don't intend to change your mind on this case. But I will show you how it even works for this case. This is the extreme of not recalling with the two-step procedure. Can you see through this? Can you see little Cooper's ligaments running through it? Can you see blood vessels running through it? Well, if you can see non-calcified blood vessels and Cooper's ligaments running through it, then you ought to be able to see something that big that's a spiculated mass. Because if the dense tissue isn't obscuring Cooper's ligaments and blood vessels, how can it obscure that? So I didn't recall it, and I was right, but this is the extreme, and I don't expect you to do it. I'm just showing you an example of how the two-step process even works when you don't think it would work. Okay, so the answer is you could get away with no recall, but you wouldn't. All right, here's another one. We're okay. So this is a focal asymmetry, right? It's a fairly good, I'm going backwards, forwards. Well, we've got priors. This is the current one. Here are the MLOs. We've got a 2-year ago, a 4-year ago, and a 9-year ago. We've got priors on the CC also. Here's the current. Here's 2 years ago, 4 years ago, 9 years ago. The positioning on the CC is a little bit different, so each one looks a little bit different. But has this thing really changed? No. It's stable for 9 years. Well, what's a focal asymmetry that's stable for 2 to 3 years? It's benign. So what's one that's stable for 9 years? It's benign. So the answer is no recall. Okay, what about this one? All right. This is I'm not showing you the other breast. This is the other breast doesn't have anything in it. It's normal. Is there a focal asymmetry or an asymmetry? Well, there's this, right? Yeah, that. That's what you see first. That's what you're going to work up first. This is a one-view asymmetry. If that's all you had, it could be no recall because of the two-step procedure. It's included in the image field, and there's nothing dense enough to obscure that. So it could be, but if you didn't, you'd recall it and you'd get the same answer. It would be summation artifact. Okay? There's a second finding.
I would no recall that, and not the first one.
Yeah, I would no recall it too. Using the two-step procedure of it's not cut off here, and also there's nothing dense enough to hide that. So I wouldn't recall it, but some would. And then you just have a higher recall rate and you wouldn't find any more cancers. But there's a second finding. Okay, the second finding is that. And it's the little ones that, these are the little ones that tend to be the cancers. So what about that? Well, does this work with the two-step procedure? No, it's too deep. It could not be included in the image field. It could be way out here. It could be way in there. It even could be in the center and just not included in the image field. So we don't have the answer for that yet. So at this point, you're thinking recall. But there is one thing that we could do, and I do this occasionally. Oh, where's my picture? Or am I going to show it to you next time? Oh, I thought I had a picture of it. This isn't going to work. And we're at time. I think I'm going to show it to you in the next group, so we'll leave it here. But take a look carefully. You see this structure right here? See this wavy structure? That's a big vein. And the vein leads right up to this. And this is medial, which is why it's so big here and so small there, because it's far away from the receptor, so there's geometric enlargement. And here's that same blood vessel here, and it's also leading right to this, which is actually that, and it's a tortuous blood vessel. Had you had tomo, it would be a no-brainer, but without tomo, you can actually call this thing a tortuous vessel and not recall it either. And with that, we'll stop because we're at time.